The postoperative pain management landscape has changed immensely from the time that I first entered the field about 30 years ago. Healthcare is an ever-changing field. Every few years, we get new technology that comes on the market, so we can really change the game for how we treat patients. One of the big changes has been the way the hospitals have changed due to new and more innovative practices, medicines, and advances to manage postoperative pain. When I was younger, I had an inguinal hernia repair. I was in the hospital for 4 days. Now, even with larger surgery, I'm disappointed if someone has to remain in the hospital even a day after surgery. The length of stay has been a big shift for providers as well as patients who benefit from improved recovery at home. Of course, nowadays, postoperative pain is typically managed with opiate prescriptions, both in the hospital and at home. These have typically been used to treat acute pain for the first few days after surgery and, of course, are readily available and relatively inexpensive. However, opiates come with significant health system and systemic cost. In my current practice, I work closely with the surgeons and other members of the surgical team to coordinate our acute pain management approach. I prefer to rely on a combination of pharmaceutical agents to ensure we effectively treat pain with as few opiates, if any, as possible. Surgery can be painful of all types, especially within the first 48 to 72 hours after surgery. Inflammation at the surgical site can limit the efficacy of local anesthetics by making it more difficult to penetrate the nerve cell membrane and reach the intended site of action. The primary reason that most longer-acting local anesthetics are less effective beyond 12 to 24 hours may be due to inflammation at the wound site, which increases the acidity. Acidity decreases the ability of the local anesthetics to penetrate the nerve cells and to block pain signals. Anything that we can do to be able to reduce the inflammatory response in that first 72 hours is so important for the patient's recovery. While local anesthesia has historically been a big component of getting patients out of the hospital quickly, there are now new pathways and medicines to take advantage of. It's crucial to have non-opiate alternatives like ZYNRELEF to provide pain relief through 72 hours after surgery. ZYNRELEF is the first and only extended-release dual-acting local anesthetic. It's administered via novel needle-free application into the surgical site following final irrigation and suction and prior to suturing. It's been clinically proven in phase 3 studies to reduce pain intensity for up to 72 hours after surgery and reduce or eliminate the need for opiates in many patients. ZYNRELEF patients experience superior pain relief through 72 hours compared to patients receiving the current standard of care, bupivacaine hydrochloride solution, following bunionectomy and herniorrhaphy. In the 2 phase 3 studies, ZYNRELEF also demonstrated a statistically significant reduction in opiate use compared to those treated with bupivacaine hydrochloride solution and placebo, with significantly more patients requiring no opiates. The unique formulation of ZYNRELEF combines the local anesthetic bupivacaine with a low dose of the non-steroidal meloxicam. Meloxicam is a potent non-steroidal with long half-life that has demonstrated synergistic activity with bupivacaine in ZYNRELEF. Meloxicam in ZYNRELEF works to normalize the acidity levels at the surgical site. It does so by lowering the concentration of hydrogen ions in the environment, which potentiates the analgesic efficacy of bupivacaine through 72 hours. Throughout my career, I've used a fair amount of other local anesthetics and had decent success. However, the quality of pain relief that comes from using ZYNRELEF has made a significant difference in quality of pain postoperatively. While some other local anesthetics have been on the market longer, ZYNRELEF has proven to be effective at providing pain relief through the first 72 hours following surgery, or the severe pain stage, regardless of the type of surgery. This occurs due to tissue trauma at a cellular level. From personal experience, I can tell you the first 72 hours are certainly painful, especially for joint replacements and open abdominal procedures. Once you get the patients over that hump, there's a definite beginning to recovery. While there will still be some discomfort, patients prefer to recover at home. At home, patients are happier and they're able to work through discomfort with a postoperative multimodal analgesic regimen and physical therapy exercises. From the healthcare side, the cost savings of discharging patients the same day are amazing. As providers, we spend a lot of money taking care of people postoperatively. Shortening the hospital stay to even half a day makes an incredible economic difference. With adequate pain relief, patients are not required to remain in the hospital. Now that ZYNRELEF is approved for more surgeries, we can provide more pain relief for more patients. There are many different multimodal analgesic regimens that can be used following surgery. For lower extremity total joint procedures, I use a multimodal analgesic regimen and see the majority of the patients go home the day of surgery. We use ZYNRELEF towards the end of the surgery and typically give a dose of nonsteroidals before they leave the hospital. This approach ensures a very limited amount of opiates, if any, are prescribed. I don't pre-medicate for these procedures as a majority of my patients go home the same day. We apply ZYNRELEF towards the end of the surgery, and I may give acetaminophen and/or a non-steroidal before they leave. They may leave with a limited script of low-dose opiates for symptomatic pain relief as needed, but I recommend they take scheduled ibuprofen every 4 to 6 hours. It's important they stick to the schedule of the non-steroidals rather than using it for relief and waiting for the pain to appear. However, that's the extent of scheduled medications I provide them, and I don't need to prescribe extra opiates. My plan in the future is to cut back on prescribing opioids and not provide any opioids except for relieving more severe cases of symptomatic pain. When I first got into practice in 1991, I did a lot of total joint procedures where we relied on spinal and epidural narcotics and continuous infusions. With that routine, the patients were basically confined to the hospital bed and would stay at least 2 to 5 days. Now we're on the verge of letting patients go home after 1 day. In my current practice, we're using a spinal with 0.75% bupivacaine with dextrose, and we use an adductor canal block with 20 cc's of 0.5% ropivacaine. That means moving to minimal opioids with the hope of completely eliminating postoperative opioids to the benefit of our patients. For patient safety, we consider the total local anesthetic dose that the patient is given in the 24-hour period. Patients as well as surgeons are extremely aware of the opioid crisis and are inquiring about alternative methods of care. Patients often don't want to use opioids but feel they need a prescription just in case. There's always a concern that if they take it, it can lead to unfortunate circumstances like dependency. Patients hear a lot about addiction, but it's also important they understand the other side effects of opioids. I've seen a lot of patients experience nausea with postoperative opioid use. I also find that older patients who have a hip or knee replacement surgery and receive regional anesthesia do not experience the same pain relief, and their treatment is different. If they take opioids, the side effects can include disorientation and delirium, which can be dangerous. For all surgeries, if I'm able to get by with reducing the amount of opioids or eliminating them completely, I will. When I use ZYNRELEF with other mechanisms and modalities as part of a multimodal approach, it generally provides a high level of pain relief with little to no opioid use. The quality of pain relief that comes from using ZYNRELEF and the ability to get inside the incisional area has made a significant difference in the quality of my practice's postoperative pain management. It's very important that the whole surgery team be on the same page about the patient's hospital length of stay, therapeutics, medicines, and an overall regimen prior to going into surgery. Surgeons need to be actively involved preoperatively as well as postoperatively to understand when opiate prescriptions are actually needed rather than prescribing regardless of pain regimen used. That way, even if we don't achieve success, we're all on the same page so we know what we can change moving forward. Communication is also very important between the surgical team and the patients. In the preoperative conversations, I tell my patients that ZYNRELEF is effective and will help ease their pain. I also let them know it's applied at the end of surgery, so there may be a short period of time between when anesthesia starts to wear off and ZYNRELEF kicks in. I've found that if I have this conversation with my patients and educate them ahead of surgery, the majority of the people respond positively and are more prepared to deal with a bit of discomfort. In my experience, anesthesiologists are in a unique position to understand therapeutics we have available. We can take advantage of different pharmacological agents so their synergistic effects achieve better results than any taken alone. For me, the multimodal regimen relies on ZYNRELEF as the foundation. The forethought my team puts into planning for pain management leads to a reduction in opioids for the patient and better pain management. I've been very fortunate that ZYNRELEF has been available to me and accessible to me since it launched in July of 2021. I used ZYNRELEF in my previous practice, so when I joined my current practice, it was on the condition that I could continue using ZYNRELEF since I believe it is the future of pain management. It was not on formulary, but what I knew from my previous practice and experience that using ZYNRELEF It was something that I wanted to keep using on my patients. ZYNRELEF is starting to be more widely available. In my experience, surgeons are very open to using ZYNRELEF because the pain relief it provides, as well as the cost-saving benefits over time. I have tried to tweak things now that my focus is on orthopedic surgeons and their procedures. Using ZYNRELEF as a foundation of a multimodal analgesic regimen helps achieve a good outcome for the patient due to the synergy of meloxicam and bupivacaine in the formulation. I find that all providers involved in the pain management journey are always looking for new ways to make the patient's surgery a better experience. I recently moved practices and nearly all the surgeons I work with are open to trying ZYNRELEF and the multimodal regimen that comes along with it. In the past, I've found surgeons have been the ones who prodded anesthesiologists to use new and innovative medicines for acute pain. Improved management of acute pain allows surgeons to devote more time to procedures. Other facilities, often smaller hospitals, may not have the ability to have a fully dedicated acute pain management team due to budgetary constraints. However, having a point person be able to take advantage of and specialize in all of the latest pain management advances is so beneficial to ensure we are providing an effective option for our patients. There are many benefits to using ZYNRELEF besides a reduction in pain and opioid use, including decreased grogginess and delirium, which is especially common in older patients, less constipation, and other gastrointestinal side effects associated with opioid use. If ZYNRELEF continues to work the way I've seen, I will be in a position to use little to no opioids, and ZYNRELEF will be at the forefront of my pain relief regimen. By implementing ZYNRELEF and not using opioids, patients can experience fewer side effects. Historically, surgeons have been skeptical of using opioid alternatives, but surgeons today are happy to implement alternative methods as they ease the burden of prescribing opioids and often lead to better outcomes for their patients. We're in a unique time in the medical field that we can take advantage of different pharmacological agents, so their synergistic effects lead to a better end result for the patient. Anesthesiologists may wonder why they should back this product. One thing we should keep in mind is that we want what is best for the patients and their outcomes. As anesthesiologists, we have a unique perspective on the total patient care model and the tools available to improve the patient's pain. ZYNRELEF is our next new tool, and it's seamless to integrate into our current practices. While you still be doing blocks and other techniques, you should rely on ZYNRELEF as a critical component of the postoperative pain regimen. In my career, a couple things have stood out for making a big difference. I've seen it in the advancement of peripheral nerve block techniques, and again when we started using ultrasound to place those nerve blocks. ZYNRELEF is the next big thing. I fully believe ZYNRELEF will help me achieve my goal to cut down the baseline opioids that we previously used before ZYNRELEF became available. To me, ZYNRELEF is the new standard. Combined with a non-opioid multimodal analgesic regimen, there's no telling what that means for the future.
Indication. ZYNRELEF is indicated in adults for instillation to produce post-surgical analgesia for up to 72 hours after soft tissue and orthopedic procedures, including foot and ankle, and other procedures in which direct exposure to articular cartilage is avoided. Limitations of use. Safety and efficacy have not been established in highly vascular surgeries such as intrathoracic, large 4 or more level spinal, and head and neck procedures. Important safety information. Warning: risk of serious cardiovascular and gastrointestinal events. Nonsteroidal anti-inflammatory drugs, NSAIDs, cause an increased risk of serious cardiovascular thrombotic events, including myocardial infarction and stroke, which can be fatal. This risk may occur early in treatment and may increase with duration of use. ZYNRELEF is contraindicated in the setting of coronary artery bypass graft, CABG surgery. NSAIDs cause an increased risk of serious gastrointestinal (GI) adverse events, including bleeding, ulceration, and perforation of the stomach or intestines, which can be fatal. These events can occur at any time during use and without warning symptoms. Elderly patients and patients with a prior history of peptic ulcer disease and/or GI bleeding are at greater risk for serious GI events. Contraindications. ZYNRELEF is contraindicated in patients with a known hypersensitivity. Example, anaphylactic reactions and serious skin reactions to any amide local anesthetic, NSAIDs, or other components of ZYNRELEF, with history of asthma, urticaria, or other allergic type reactions after taking aspirin or other NSAIDs. Severe, sometimes fatal, anaphylactic reactions to NSAIDs have been reported in such patients, undergoing obstetrical paracervical block anesthesia or undergoing CABG. Warnings and precautions. Dose-related toxicity. Monitor cardiovascular and respiratory vital signs in patients' state of consciousness after application of ZYNRELEF. When using ZYNRELEF with other local anesthetics, overall local anesthetic exposure must be considered through 72 hours. Hepatotoxicity. If abnormal liver tests persist or worsen, perform a clinical evaluation of the patient. Hypertension. Patients taking some antihypertensive medication may have impaired response to these therapies when taking NSAIDs. Monitor blood pressure. Heart failure and edema. Avoid use of ZYNRELEF in patients with severe heart failure unless benefits are expected to outweigh risk of worsening heart failure. Renal toxicity. Monitor renal function in patients with renal or hepatic impairment, heart failure, dehydration, or hypovolemia. Avoid use of ZYNRELEF in patients with advanced renal disease unless benefits are expected to outweigh risk of worsening renal failure. Anaphylactic reactions. Seek emergency help if an anaphylactic reaction occurs. Risk of joint cartilage necrosis and degeneration with unapproved intra-articular use. Animal studies evaluating the effects of ZYNRELEF following intra-articular administration in the knee joint demonstrated cartilage necrosis and degeneration. Chondrolysis. Limit exposure to articular cartilage due to the potential risk of chondrolysis. Methemoglobinemia. Cases have been reported with local anesthetic use. Serious skin reactions. NSAIDs, including meloxicam, can cause serious skin adverse reactions. NSAIDs can also cause fixed drug eruption, FDE. FDE may present as a more severe variant known as generalized bullous fixed drug eruption, GBFDE, which can be life-threatening. If symptoms present, evaluate clinically. Drug reaction with eosinophilia and systemic symptoms, DRESS. If symptoms are present, evaluate clinically. Fetal toxicity. Due to the risk of oligohydramnios, fetal renal dysfunction, and premature closure of the ductus arteriosus with NSAIDs, limit use of ZYNRELEF between about 20 to 30 weeks gestation and avoid use after about 30 weeks. Hematologic toxicity. Monitor hemoglobin and hematocrit in patients with any signs or symptoms of anemia. Drug interactions. Drugs that interfere with hemostasis. Monitor patients for bleeding who are using ZYNRELEF with drugs that interfere with hemostasis. Example, warfarin, aspirin, SSRIs, SNRIs. ACE inhibitors, angiotensin receptor blockers, ARBs, or beta blockers. Use with ZYNRELEF may diminish the antihypertensive effect of these drugs. Monitor blood pressure. ACE inhibitors and ARBs. Use with ZYNRELEF in elderly, volume depleted, or those with renal impairment may result in deterioration of renal function. In such high-risk patients, monitor for signs of worsening renal function. Diuretics. NSAIDs can reduce natriuretic effect of furosemide and thiazide diuretics. Monitor patients to assure diuretic efficacy, including antihypertensive effects. Use in specific populations. Infertility. NSAIDs are associated with reversible infertility. Consider avoidance of ZYNRELEF in women who have difficulties conceiving. Severe hepatic impairment. Only use if benefits are expected to outweigh risks. Monitor for signs of worsening liver function. Severe renal impairment. Not recommended. Adverse reactions. Most common adverse reactions, incidence greater or equal to 5% in controlled clinical trials with ZYNRELEF, are soft tissue procedures, vomiting, and orthopedic procedures, constipation, and headache. Report side effects to Heron at 1-844-437-6611 or to FDA at 1-800-FDA-1088 or www.fda.gov /medwatch. Please see full prescribing information, including box warning and updated warnings and precautions for serious skin reactions caused by non-steroidal anti-inflammatory drugs, NSAIDs.